Welcome to The Explainer. Today, we are stepping right into the middle of the emergency room to crack one of the toughest cases out there, acute abdominal pain.
So, let's put you in the hot seat. Your patient is clearly in a bad way. The clock is absolutely ticking. This isn't just a medical puzzle. It's a full-blown detective case. You're the lead investigator, and what you do in the next few minutes could change everything. The stakes? Well, they couldn't be higher.
You know, before you can even start wondering what's causing the pain, you have a much more urgent mission. You have to figure out if your patient is stable. In the ER, your #1 priority isn't the diagnosis, it's stopping a disaster before it happens.
And this 3-step protocol, this is your lifeline. First, you're looking for any sign of shock. Is their blood pressure tanking? Is their heart racing? If the answer is yes, you don't wait. You start resuscitation with IV fluids right away. And at the exact same time, your brain is scanning for any other immediate threats that need to be dealt with, like now.
And this is such a critical distinction to make. Resuscitation, that's for a patient who is already in shock. You are literally pulling them back from the brink. Urgent treatment, on the other hand, is for the patient who is about to go over the cliff. Think of someone with a ruptured aortic aneurysm. They might look okay for a second, but you have to act before they crash.
Okay, so you've made sure the patient isn't in immediate, life-threatening danger. Now the real detective work can begin. And your single most powerful tool, bar none, is simply listening to the patient's story.
But to get that story right, you need a system. You can't just wing it. And that's where the SOCRETES mnemonic comes in. It's the perfect toolkit for the job. It's basically a guided conversation that makes sure you hit every single detail about the pain. Where it is, how it started, what it feels like, the whole shebang. It guarantees you won't miss a vital clue.
And sometimes a single detail can just blow the case wide open. When a patient says the pain came first and then the vomiting started, well, your detective spidey senses should be tingling. That exact sequence is a classic clue pointing towards a surgical problem, something like appendicitis.
But a good detective never gets tunnel vision. You've got to broaden the investigation, right? So you'll ask about bowel habits, sure, but then you'll look for accomplices, symptoms in other parts of the body. Because a problem in the lungs or even the heart can show up disguised as belly pain. And of course, you check their file for any prior history.
So, let's move on. You've gathered all the testimony, now it's time to examine the physical evidence. You are literally searching the scene of the crime, the patient's body. Before you even touch the patient's abdomen, you look at the body's dashboard, the vitals. Heart rate, blood pressure, temperature, O2 sats, these numbers give you an instant, objective snapshot of how the patient's system is coping with whatever's going on.
And here's a really important point in modern medicine. If you gently press on the abdomen and it hurts, that's called tenderness, that's your clue, that's enough. The old school move of checking for rebound by pressing down hard and then letting go suddenly, we just don't do that. It's unnecessarily cruel, and frankly, it doesn't give you any new information.
All right, so your initial history and physical exam, they've given you some pretty strong leads. But to really confirm your suspicions and to find any hidden evidence, you gotta call in the forensics team. For us, that's the lab and the imaging department.
Think of this as your forensics menu. Every single test is there to answer a very specific question. A quick blood sugar check can unmask diabetic ketoacidosis. A urine test can spot a UTI or, crucially, an ectopic pregnancy. You get an ECG on older patients to make sure a heart attack isn't the real culprit. And then, of course, imaging, like a CT scan, lets you literally see inside to find the problem.
Okay, the evidence is all on the table. You've got the story, the exam, the lab work. Now comes the real brain work of being a detective. You build your list of suspects. In medicine, we call this the differential diagnosis.
And to keep it all organized, you can basically group every possible cause of acute abdominal pain into one of 3 big buckets. Is this a surgical problem? Is it a medical issue playing dress-up? Or, if your patient is female, could it be gynecological?
So your surgical lineup has all the usual suspects, right? Things like appendicitis, a fired-up gallbladder, a blocked bowel, or something really catastrophic like mesenteric infarction, where the gut's blood supply gets cut off.
Then you have your medical suspects. Oh, and these are the true masters of disguise. A heart attack, pneumonia, even DKA. They can all show up screaming abdominal pain and send you looking in completely the wrong place.
And this is absolutely non-negotiable. In any female of childbearing age, this list of suspects has to be top of mind.
An ectopic pregnancy is a true can't-miss emergency, and things like a ruptured ovarian cyst, or PID, are also really common culprits.
Now, here is probably the most crucial piece of wisdom for any medical detective. When you hear hoofbeats, think horses, not zebras. It is so much more likely that your patient has a really common problem that's just showing up in a weird way than it is that they have some super rare disease. Always start with the most likely culprits first.
Okay, you've looked at all the evidence, you've narrowed down your suspects. Now it's time to make a decision, to set a plan in motion, and just as importantly, to be super aware of the common traps and red herrings that can trip you up. Your initial plan is pretty straightforward, and it's got 3 parts. 1. Keep stabilizing the patient with fluids. 2, and this is so important, relieve their pain. Get them comfortable. And 3, bring in the specialists. You get the surgical team involved to make that final call on what happens next.
And this just shows what a huge shift there's been in medicine. The old idea that giving pain meds will somehow mask the diagnosis, it's been proven to be totally wrong and, honestly, just cruel. A patient who isn't in agony is a patient who can help you, who can cooperate with your exam. It actually makes the diagnosis easier.
Finally, every good detective needs to know the common pitfalls. The elderly might not have a fever even if they have a raging infection. Lab tests can lie to you. A normal white count doesn't mean there's no sepsis. And you have to be really wary of a patient who is in 10 out of 10 pain, but their physical exam is kind of normal. That mismatch can be a terrifying sign of a vascular disaster. So at the end of the day, what does this whole detective process show us? It's not just a checklist. It's a way of thinking that blends science and observation with pure human empathy. It reminds us that every patient is a unique puzzle, and our job is to put all those clues together to crack the case, and most importantly, to help them heal.